We have measured inflammation in the blood. We have measured two substances that are produced by white blood cells. And we found that patients with depression that have elevated levels of both these substances are basically unable to respond to the classic first-line antidepressant that would be prescribed by any physician. It really helps changing the theoretical framework with which we see depression, not only as a disorder in the mind, but actually something that affects both the brain and the body. So it's really like another mainstream medical disorders.
This is huge on lots of levels when you think about the perceptions that people have of the way in which depression manifests itself. What is it that you would then be able to use this for? Would it be a way of identifying a particular kind of depression, because there are so many?
Some people, for example, may have immune gene variants that are more likely to be hyperreactive. So the same genes that predispose you to rheumatoid arthritis or to other forms of autoimmune disorders could also predispose you to increased risk of depression by increasing your immune reactivity. Some other people may have increased inflammation because of what we call a neurodevelopmental component. So for having been exposed to life trauma early in their life or repeatedly throughout their life. So I think high level of inflammation signal a depression which is more embedded in the individuals, and that's probably why it's also less likely to respond to the first-line antidepressant. While it's different if you have had a reasonably normal, resilient life and then something bad happened when you're an adult and you develop one episode of depression, it's probably a different kind of depression.
And how would it make an impact on the much more severe sorts of mental illnesses, such as schizophrenia or a bipolar disorder, which goes from depression into manic episodes?
This research is opening the way to the possibility of looking at inflammation also in other mental health disorders and potentially using it as a therapeutic target. We have fewer data. There's some promising evidence, for example, in schizophrenia, that adding an antidepressant to an antipsychotic improves the beneficial effect of treatment, but the numbers are much smaller than, let's say, compared with depressed patients that have been treated this way.
How important do you think these findings are in the kind of social context of how we perceive mental illness?
I think they're really important because it brings up the notion that depression is not a psychological weakness, is not something only in the mind, and we really think it will help destigmatizing depression by explaining that the brain and the body are affected. Mental health and physical health are so linked together that you can't really separate them.
And I suppose that there are those who might argue that this is too much medicalization. That's the other side of the argument.
Yes, so we should never give antidepressants to people that don't need them, but at the same time we must make sure that people that do need antidepressants receive them. I'm a psychiatrist. I would never prescribe an antidepressant to someone that is, for example, very upset or distressed because of a life event that has happened recently. I know from clinical experience and just by talking with colleagues that we're all very respectful to the fact that in some individuals depression is an understandable reaction to a life event. It brings suffering but also brings growth, and sometimes it's about changing in life that are important. But at the same time, we have to be able to recognize some individual in which depression is having such a negative impact on their life that we can no longer procrastinating treatment.
At what stage is the study in terms of the impact it will make on potential patients?
So what we now need to do is, first of all, identifying what is the best new antidepressant strategy that we could offer to this patient, and we are now conducting a study combining an anti-inflammatory with an antidepressant to see whether it's more effective in the treatment of depression. This is actually ongoing at the moment. Probably what the anti-inflammatory will do is, by taking away the impact of inflammation on the brain, it will make the brain more responsive to the antidepressant. So together will allow the antidepressant to become efficacious again, while it normally wouldn't. But we also want to conduct a larger studies testing whether using this blood test in a real life NHS settings actually improved the outcome and the quality of life of a larger number of depressed patients. And if that is proved, then it could be rolled out in clinical practice.